Good afternoon. Today our group will be presenting our case study of Maria. Maria is a 55-year-old female. She is obese and she works 40 hours per week as a nurse. She presents to our clinic with pain around the fourth metatarsal, and we suspect that the cause is one of two options: fourth metatarsal stress fracture at the neck or intermetatarsal bursitis. Stress fractures are defined by Fetzer and Wright as a fracture of the bone that occurs as a result of repetitive loads acting on the bone. Patients typically present with a history of acute or repetitive trauma to the forefoot. Some symptoms include pain exacerbated by weight bearing, pain on palpation of metatarsal shaft, swelling and ecchymosis, fairly localized pain initially, however, disperses with swelling. To confirm the symptoms are a result of metatarsal stress fracture, there are some diagnostic tests that can be performed, which will be elaborated on later. These include MRI scans, X-rays, bone scans, nuclear scanning, and ultrasound. Radiation is typically measured in sieverts, and the body is exposed to around 3.0 millisieverts per year on average. Typically, radiation from scans relating to the foot are relatively low, less than 0.1. However, caution and care must be taken to ensure exposure is limited.
Strauch and Slomiani have credited that some authors also have proven that a vibrating tuning fork in the area in question can bring back a positive result, as the vibrations from the tuning fork will cause Maria pain in the fourth metatarsal, if it is indeed a stress fracture. Diagnostic imaging such as X-rays are commonly used to first identify stress fractures, as they are relatively inexpensive, only costing patients $36.90. However, they are considered not to be very effective due to their difficulty in detecting stress fractures in their early stages, which can be 3 months after symptoms first appear. However, as a beneficial, it can potentially rule out any factors such as tumours and infections. Snyder et al. Conclude that X-rays have a sensitivity of only 26, whilst having a specificity of 100%, whilst Berger, de Jonge and Mass make evident that a follow-up X-ray presents sensitivity increases to anywhere between 30 and 70%. Ultrasounds are considered to be relatively cheap, only costing $92.75, although this form of imaging is not considered to be particularly effective due to their lack of sensitivity only being 64% and specificity of the 63%. Bone scans, however, are considered by Snyder et al. To be one of the two gold standard diagnostic tools for identifying stress fractures, as it can recognise areas of bone that have larger absorption of radioisotopes. Bone scans have a sensitivity of 100% and specificity of 76%, making them an extremely useful imaging option. MRIs are deemed by Snyder et al. To be the other half of the gold standards in diagnosing stress fractures, as Berger, de Jonge and Mass state that MRIs have a similar sensitivity to bone scans, scoring 100%, as well as a higher specificity of 86%. MRIs tend to present the stress fractures as a brighter image, and MRIs tend to be frequently used as they are not as invasive as bone scans, as well as providing a greater amount of detail displayed in images. However, Snyder et al. Highlights that MRIs are more costly than bone scans.
The second differential diagnosis given by the podiatrist was intermetatarsal bursitis. I will first give a few definitions relating to the pathology before discussing the clinical and diagnostic tests that can be completed to confirm the diagnosis. What is a bursa? A bursa is a synovial lined sac overlying the bony surfaces at areas of tendon friction. Bursa are located where tendons move against each other or glide over a bony surface. Bursitis is a pathological thickening of the bursa walls due to inflammation resulting in an enlargement of the bursa. The pathogenesis of intermetatarsal bursitis currently remains unclear. It has been suggested that the inflamed bursa compresses the interdigital nerve. According to Zanetti and Wishop 2005, in the radiological literature, intermetatarsal bursa are only rarely mentioned. If intermetatarsal bursitis is suspected, history taking and clinical tests are important to differentiate between stress fractures and other forefoot pathologies. Observing if there is any erythema and edema around the web space, as well as palpating and squeezing the web space, may reproduce pain. Assessing footwear could also indicate intermetatarsal bursitis, as narrow shoes that compress the digits have been associated with the pathology. An inflamed bursa can be visualized by ultrasound, as the ultrasound beam is able to penetrate the area. The bursa is visualized as fluid on the ultrasound. Intermetatarsal bursitis is recognized on ultrasound as an anechoic area between the distal heads of the metatarsal bones. They appear similar to ganglions but are compressible. The image on the right is showing the change in fluid when the bursa is compressed. This is used to differentiate intermetatarsal bursitis and Morton's neuroma. Advantages of ultrasound for diagnosing intermetatarsal bursitis include it's fast, inexpensive, accurate for showing large range of forefoot pathologies, it's painless, there's no ionising radiation, immediate feedback is received, and for negatives it's highly operator dependent. Sensitivity is 82.4% and specificity is 88.9%. MRI has also been used to confirm the diagnosis of intermetatarsal bursitis as a high T2 fluid-filled structure. Intermetatarsal bursitis can be visualized as an increased signal on T2 weighted images in typical location around the metatarsal shafts. Bowen et al. Found that ultrasounds were quite reliable, but other gold standard imaging techniques such as MRI and CT have had very little research into the sensitivity and specificity for diagnosing intermetatarsal bursitis. A positive of MRIs is that they have a large scope for imaging a large array of forefoot disorders and no ionising radiation is used. A negative is expensive and there's little evidence into its effectiveness in diagnosing intermetatarsal bursitis.
Clinically, there is pain on palpation for both intermetatarsal bursitis and stress fractures. The two injuries are palpated at slightly different areas. The intermetatarsal bursitis has pain present in the web space, and the metatarsal stress fracture will have pain along the metatarsal shaft. The tuning fork, as mentioned before, can also be used to reproduce the pain of a stress fracture. The ultrasound is the first option for intermetatarsal bursitis, as we are looking for swelling and inflammation in soft tissue. It is fast, inexpensive, and has no ionising radiation, and has sensitivity and specificity for metatarsal bursitis. X-ray is the first option for diagnosing stress fracture. It is inexpensive, 100% specific. If nothing shows up in the X-ray, the patient can be sent back after 10 to 14 days, as 2 X-rays are still more cheaper than 1 MRI. If no diagnosis is made from either the X-ray or the ultrasound for the respective injuries, an MRI can be taken. As said earlier, a larger range of tissue can be visualized in using an MRI with a low dose of radiation. MRI also has sensitivity of 100% and higher specificity than bone scan. If there is no conclusive evidence of a stress fracture in an MRI, it can then be taken for a bone scan. We use the Pedro scale to critically appraise the journal article by Bowen et al. 2008, the musculoskeletal ultrasound imaging of the plantar forefoot in patients with rheumatoid arthritis, an inter-observer agreement between a podiatrist and radiologist. Database search was Medline, 1998. Search terms, MSU, forefoot, bursitis. Pedro scale was 8 out of 11, which suggests that the data obtained by Bowen et al. Was of a sufficient quality.
We performed a critical appraisal of a systematic review on stress fractures. The title of the article was called The Ability of Clinical Tests to Diagnose Stress Fractures, a Systematic Review and Meta-Analysis. This review was performed by Snyder et al. In 2012. We obtained this article from the Cochrane Library using the search terms diagnostic imaging stress fractures. We chose a systematic review as the Oxford Centre of Evidence-Based Medicine 2011 believes that systematic reviews are a level 1 category of evidence, which is the highest level of credible and quality evidence that can be gathered.
Thank you for listening to our presentation.